And so we are so grateful that we have kept time. For the members who will be joining us, they will find us moving. So once again, join me to welcome our board chairman, Dr. Albert Biamogisha, our executive director, Dr. Chris Mokiza, and all the other members of the board who are present. But also, I take this opportunity to welcome members of the bureau, staff, the media. Thank you for keeping time. So in a few minutes from now, we shall be starting the main session. Definitely, as you say in the program, we have arrival and registration of guests. I think some people have gone for breakfast, dear Edie, but they are being called to join us because it is already time. We shall have the opening prayer and anthems. We shall have a welcome remark from our dear executive director. We shall also have opening remarks from the chairman board of directors of Uganda Bureau of Statistics. We shall have the remarks from Minister of Health, Global Fund representative, World Health Organization, United States, and then we shall have presentation of key findings. After the presentation, we shall have remarks by the chief guest of state for planning in the Ministry of Finance, Planning and Economic Development. We shall thereafter have a panel discussion, a plenary, and then we shall have lunch and departure. So that is how our program is. Ladies and gentlemen, once again, I want to welcome all of you to this dissemination of Malaria Indicator Survey 2025. Just remind you that this survey was launched sometime back in December 2024 by the Minister of Health. And of course, the team went to the field. And today we are here to receive the findings that is going to be disseminated to us in a few minutes from now. Very shortly, we are going to be joined by our chief guest, and then we shall officially start the session. So once again, I take this opportunity to welcome all of you. And in the most special way, I would like to welcome the delegate from the World Health Organization. She's here with us. You're most welcome, madam. From Global Fund, from the Minister of Health, from Center for Disease Control, Uganda Virus Research Institute. We have delegates from the United States Embassy. They are already here. And so we are happy that we are able to have this day and share with us the latest as far as malaria control prevention is the current status in Uganda. But of course, we all know that malaria is still a big burden to most of the African countries. And there are indeed several efforts that have been put up by various countries to ensure that malaria can be dealt with completely among children, among pregnant mothers, and the general population. So this has been a serious disease in many of the African countries. And so, soon, I think with these critical indicators or statistics, this problem will be dealt with decisively, especially from the policy point of view. Members who are scattered far behind, it would be nice that we fill up the front pews, and those who will be joining us later, they can occupy those seats. So just move down so that we can first cover up these front pews. And will also, of course, reduce on our being seen to be a little disorganized. It would be better that we leave the behind pews completely free for those who will be coming in late. Are members from the other side listening? So could we please do the needful? Okay. Just to remind you again, we are here for the dissemination of Malaria Indicator Survey 2025. This survey has gone through all the basic standards of statistical production, and we should be happy that we are going to receive very quality information today. And of course, it will be the responsibility of our users to actually make good use of this data. And I know that as we go along, some of this emphasis will be coming through from the different remarks that we shall be receiving from our distinguished guests who will be speaking to us today. I already told you that the minister is on his way here. The board chairperson of Uganda Bureau of Statistics is already here. The ED is present. We have a number of stakeholders from Makerere University, School of Public Health. We also have participants from the local government. I'm seeing Wakiso District Local Government. Minister of Health is highly represented, and I think they are the key users of this important information. We have Minister of Agriculture, Animal Industries and Fisheries. We have Minister of ICT. We have Uganda AIDS Commission. All these important persons are here. Very importantly also is World Health Organization is here present. United States Embassy, Uganda Virus Research Institute, and of course the producers of statistics, UBO staff. As we wait for our guest of honor, allow me to take recognition of our dear Executive Director. He's here with us. Let's clap our hands thunderously and welcome our dear Minister for State Planning and Economic Development, Honorable Amos Lugolobi. Dear sir, you are most welcome, Honorable, to this very important occasion when we disseminate the Uganda Malaria Indicator Survey. I will not be able to take you through the background because you will actually be able to see it in the presentations that will come along, and also with the findings and the various remarks that you'll be hearing from our ED, our board chairman, and the rest of the presenters today. So ladies and gentlemen, we are going to start officially, and we are so glad that we are here with our minister already in the house. We shall be having the anthems, we shall have the prayer, and then quickly we shall have the welcome remark from the Chief Statistician of Uganda, Dr. Chris Mukiza. We shall also have the opening remark from our board chairperson, Dr. Albert Biamugisha. We shall be having remarks from the PS, Minister of Health, Global Fund representative, World Health Organization, United States Embassy, and then we shall be having, of course, presentations. So once again, thank you all for coming and keeping time. Dear Chief Guest, our program started officially at 10:30, and we are just 15 minutes into that time, and we are also very happy that you have already arrived. So I'm going to request all of us to stand up for anthems and then prayer. Oh, Uganda, may God uphold thee. We lay a future in Thank you. Let's remain standing. Nancy Anyango, please come and give us a word of prayer.
Let's humble ourselves for a prayer. Heavenly Father, we want to thank you for yet again another opportunity to be alive and to be in this place. God of mercy, we thank you that with you we know that everything we've planned today is going to succeed. Father, we thank you that on the in 2024 December, when we launched this survey, you carried us through and you enabled us as the Bureau to be here today, that we are ready to disseminate this report. I commit every deliberation, every discussion, everything that will be deliberated upon in this place in your hands, that we shall take everything that has been shared here and use it for the betterment of our country. I thank you and I bless you. In God's name I've prayed. Amen.
Thank you very much. We may take our seats. Our dear guest of honor, Honorable Amos Lugolobi, would like to let you know that officially today we are disseminating the malaria indicator survey. And it is also important for you to know some of the guests that you'll be interfacing with here today. We have a number of stakeholders coming from the Ministry of Health. We have participants from United States Embassy, World Health Organization, Uganda Virus Research Institute, Makerere University School of Public Health. We have representatives from Ministry of Agriculture. We have representatives from the media fraternity, who are our good friends and also champions in dissemination of information. We have members of staff of Uganda Bureau of Statistics. We have participants from the local government, the Minister for Local Government, but also local government at a district level. They are here with us. We have other participants from Ministry of ICT, USAID, TASO, and so on and so forth. So our guest of honor, we are glad to have you here with us this morning, and we pray that your presence makes this function even more colorful. But also allow me to, in a special way, welcome our board chairman, Dr. Albert Biamugisha, our board member, Dr. Allen Kabagenyi, our dear ED, and also the Chief Statistician of Uganda, Dr. Chris Mukiza, our Deputy Executive Director, Dr. Vincent Fred Senono is here seated, and all the distinguished guests, ladies and gentlemen, you are all most welcome to this very important exercise of dissemination of the Malaria Indicator Survey report. Without wasting time, allow me to take this singular honor to invite our Executive Director, Dr. Chris Mukiza, to welcome us to this very special session. Dear ED and Chief Statistician of Uganda, you are most welcome to humbly welcome our participants for today. I have not heard the clap. That's not how we welcome the ED. Can we give the ED a thunderous hand clap? Thank you so much.
Our chief guest, who is the Honorable Minister responsible for statistics, Honorable Amos Lugolobi. The World Health Organization representative, representatives from the development partners, the Deputy Principal, College of Medicine, Makerere University, and your entire top researchers here. We recognize Professor Moses Kamya, together with the team that you have come with. The chairperson of Uganda Bureau of Statistics Board, board members here present, senior management team, Uganda Bureau of Statistics, staff, the media fraternity, representatives from all government ministries, departments, agencies, and particularly Minister of Health. Ladies and gentlemen, good morning. Good morning. I hope malaria has not caught with you. I take this opportunity to welcome each of you as here in our capacities to this occasion at the national dissemination of the Uganda Malaria Indicator Survey of 2024-25 report. I repeat, I take the opportunity to welcome each of us in their distinguished capacities to this national dissemination of Uganda Malaria Indicator Survey 2024-25 report. On behalf of Uganda Bureau of Statistics, we wish to express our sincere appreciation to all stakeholders who have joined us today to reflect on the findings from this survey. Your presence demonstrates the continued commitment to strengthening evidence-based planning and decision-making. This is the first of the 8 series we are going to disseminate from the surveys and the censuses we concluded. The Uganda Malaria Indicator Survey is one of those, and it gives us comprehensive indication on malaria, including prevalence patterns, prevention, treatment, and control efforts in the country. Over the years, these surveys have played a vital role in tracking progress and informing national malaria control strategies. The 2024-25 Uganda Malaria Indicator Survey was conducted through close collaboration between the Bureau and the Ministry of Health, because they are experts anyway, with support from several government partners, notably those funded by the President's Malaria Initiative, the United States of America's Malaria Initiative, the United Kingdom through Department of International Development, the World Health Organization, the Global Fund to fight HIV, tuberculosis, and malaria. So through our Honorable Minister, we would like to thank government for continued investment and prioritizing statistics through constant funding. 70% of the funding was from government of Uganda. And we want again to thank you, Honorable Minister, for funding us to do our professional work. The survey, as we shall see, collected critical information on a number of key indicators, including household ownership and the use of insecticide-treated mosquito nets, intermittent preventive treatment for malaria during pregnancy, malaria testing among children under 5 years of age, knowledge and practices related to malaria prevention and treatment. Data collection was, of course, conducted using the digital technology. We have moved away from paper, which is in line with our objective of improving quality, accuracy, and timeliness of the data collection, and also saving our environment. because each paper we do is a tree cut. And we have to be mindful of our planet. We wish to commend the dedicated team of nurses, health technicians, supervisors, and field interviewers who work tirelessly to collect this data from communities across the country. Their commitment and professionalism ensured that the survey was successfully implemented. May I recognize the representative from field interviewers? Are they here? Do you have 1 or 2 or 3 or 5? What about the supervisors? You don't have supervisors. Here and I know you have your staff who supervise. They are not willing to show up. Okay, we don't want to shine and the minister sees it, it's up to you. They are not here. At the Uganda Bureau of Statistics, I can see you come and show what you did. Stand here, the minister recognizes you. Okay. These are the supervisors, but you have not come with your field workers. Next time, the way you cannot be owned by commanders only. Okay, thank you. At Uganda Bureau of Statistics, we remain committed to our mandate of producing quality statistics and publishing the official statistics at the same time to everybody that is concerned. So we ensure equal access to school product to everybody at the same time. I can assure even the minister has not seen what you are going to disseminate. And that's very important, so that we preserve the quality aspects of the data we produce. We are also still committed to coordinating the national score system and producing evidence-based information that supports planning. As we disseminate these findings today, we would like to encourage all stakeholders to make full use of data-generated strengthened policies, programs, and interventions aimed at eliminating malaria and improving the general health outcomes of Ugandan citizens. In December, we are told malaria was the highest, the #1 killer disease when we are launching this survey. So all efforts should be aimed at eliminating malaria, and using this data, we can get ways of achieving that goal. We encourage the media here to please communicate and propagate these statistics further for wider usage. And please use the language that Omuntu wants you to understand. For us, we may start talking technical things. I have now experts in medicine here. I saw a statistician is now like a doctor. They are talking about so many things. When you say those things, please interpret them to our people so that they understand them. With these few remarks, I once again welcome all of you here and wish you nice deliberations for God and my country.
Thank you very much, Doctor, our Executive Director and Chief Statistician of Uganda. A very big hand clap to the ED for such a very wonderful, welcome remarks. When ED talked about the foot soldiers, I thought that our participants would give them a very big hand clap. Let's clap for them. These people in the field looking for the data. They deserve appreciation. And ED Thank you so much for recognizing them and their very empirical contribution to the data collection processes and the overall production chain of these particular statistics. We thank you. Ladies and gentlemen, we are working within the interest of time and recognizing that people are busy, and it is also part of discipline to respect time. I want to take this opportunity, therefore, to invite none other than our board chairperson, Dr. Albert Biamugisha, who's here with us, to come and open this session so that we can then receive what has brought us here today. Doctor, you're most welcome. A big hand clap as we welcome our board chairman.
Thank you very much, our Director of Ceremonies this morning, Honorable Minister, State for Finance, Planning and Economic Development, and our Minister in charge of Statistics, Honorable Amos Silgorobi. You are most welcome. Now we have representatives from development partners who have contributed, represented by the representative from World Health Organization, representatives from Ministry of Health, members of the Board of Directors, and we have now Dr. Kabagenyi representing the board. Then members of management who are here, but of course we have Dr. Chris Muchiza, who is the Executive Director, the board member, and then all of you, the media and distinguished guests, ladies and gentlemen, good morning. On behalf of the Board of Directors of Uganda Bureau of Statistics, I am honored to welcome you to this important occasion for the launch of the Uganda Malaria Indicator Survey report. Before I proceed, let me introduce to you my board members, few board members who are here. We have Dr. Allen Kabagenyi. For recognition, you can stand up. She represents academia from Makerere University. We have Dr. Chris Muchiza representing management, and the others have not come, who they may come, but at least these ones are representing them. So the board takes great pride in fostering a conducive environment for executing the Bureau's mandate as outlined in the UBOS Act of 1998 to coordinate, monitor, and supervise the national statistical system, in addition to being the source of official statistical information. So, ladies and gentlemen, to deliver quality statistics that support national development, Uganda Bureau of Statistics conducts periodic surveys and censuses, produces key indices, and develops as essential products. Reliable data is not merely a technical tool for policymakers. It is a strategic national asset that empowers government and development partners, plus researchers, to make informed decisions, ultimately improving the lives of our citizens. The Uganda Malaria Indicator Survey is one of the key national surveys that provide critical data to guide the fight against malaria and strengthen health sector planning. However, malaria remains again, as we have not heard from ED, one of the leading public health challenges in Uganda. The disease continues to account for a significant proportion of outpatient visits and hospital admissions, particularly affecting children under 5 and pregnant women, and as such, the data generated through the Uganda Malaria Indicator Survey therefore provides a platform to monitor Uganda's progress toward achieving sustainable development goals. Goal number 3 is for well-being of human beings, and sustainable development goals indicators out of 17 The third one, of course, is on this one here. So this ensures lives and promoting well-being for all the ages, particularly under the incidence of malaria. And again, in my other capacity as the head of Sustainable Development Goals Secretariat, the Office of the Prime Minister, I wish to emphasize that national surveys like this one are critical for tracking Uganda's progress towards sustainable development goals and the Agenda 2063, the Africa we want, and informing policy responses. For instance, for the Agenda 2030 for Sustainable Development Goals, there are 17 goals, and we have 232 indicators, of course, for 169 targets. And out of that, out of the 17 goals, goal number 3 concerns health. And health has 25 indicators out of the 232. And by the way, we are not able to measure all. We can measure 201, which are eligible for Uganda. But now we are at 148. But we have risen from 41 since 2016. So which means UBOS has done some good work. 41 indicators with good data in 2016. Now we are at 148 as per yesterday. Because I have not seen the data, we are going to disseminate. And some of the indicators definitely are providing data for what we have not been measuring. So which means we are going to have more than 148. So we may be at 150, which is very good because a country, Office of the Prime Minister is preparing a national conference next month, which will be presided by the president and whatever. But of course now, this will be very good news when we talk about the data. And that makes Uganda being the first and the best now with the data points in Africa on SDGs. Others have 60, 70, you can Google. 90, we are at 148, but we are going to have plus. So which means it makes us very strong. So we are very proud of the Bureau for producing this credible information that it can not only inform the policymakers, but even the international community. How is that? For example, Minister of Health actually has worked very hard. And when you look at some of the key indicators, I can give C examples. One is under 5 mortality, which has reduced significantly from about 90 deaths per 1,000 live births in 2011 to about 46 deaths per 1,000 live births in 2024. That is a very big achievement, and in Africa, there we take position number 1. Number 2 is maternal mortality has also declined from approximately 438 deaths per 100,000 live births in 2011 to about 207 deaths per 100,000 live births, which is very, very good also. Then the third one, infant mortality has also declined from 54 per 1,000 live births in 2011 to 34 deaths, from 54 to 34 in 2024. So now the other one is malaria incidence, which is indicator number 3.3 something. So I don't know what data you have, but at least it's going to be added on. Then there is immunization and so forth. So at least that's very fine. So these achievements demonstrate the impact of sustained investments in the health sector and the stronger collaboration between the government and development partners. Ladies and gentlemen, the availability of reliable statistics enables the government for 4 purposes. 1, to monitor progress on national development priorities. Number 2, to track the international commitments. We are talking of Sustainable Development Goals, Agenda 2030. We are talking of Agenda 2063, the Africa we want. We are talking of Agenda 2050 of the East African community. Those are the international ones. So we are able now to track them because it's a requirement of government that in July every year we produce a report that informs the something to report, different from what we reported on last year. Then it guides effective resource allocation and then strengthening accountability and service delivery. Distinguished guests, as a board of directors of Uganda Bureau of Statistics, we remain committed to supporting the Bureau in strengthening Uganda's national statistical system and ensuring production of high quality statistics that inform national decision making. We will continue to support investments in modern statistical systems, capacity building, and innovation in data collection and analysis. Allow me, chief guest and colleagues who are attending this launch, to once again commend the technical team from Uganda Bureau of Statistics who did the work, the Minister of Health, because you did it with Minister of Health, and our development partners for their collaboration and professionalism in successfully implementing this survey. As we launch this report today, it is important to remember that the true value of statistics lies not only in their production, but in their effective use. So the evidence contained in this report should guide policy decisions, strengthen malaria control strategies, and ultimately contribute to improving the health and well-being of the people of Uganda. So before I take my seat, allow me to express our sincere appreciation to our minister in charge of statistics, not only statistics, together with also planning and SDGs and everything, Honorable Amos Rugorobi. Please, a very big clap. I'm not hearing that. Can you add more? As indicated by the accounting officer, for his continued support to the national statistical system and for the government's commitment to financing the critical statistic programs. You know, government doesn't simply give money anyhow. You boss, NPA, where. No. There must be someone to present and fight for it. And indeed, in some cases, I have accompanied the ministers in the cabinet, and our minister has fought very hard. So when you listen that we have got a series of eight disseminations, some people were saying, is it true? 8 disseminations? Because surveys are very expensive. So, Minister, definitely there is a reason why we should smile and actually thank you for that one. It's a pride for us. Numbers of indicators are increasing, and then whatever, and the Bureau, you see, is ready to work. You have attracted the development partners, and I'm sure they will give us even more money to that one there. So your leadership in strengthening evidence-based planning has enabled institutions as the Bureau of Statistics to continue producing reliable and high statistics that inform national policy and development partners, and we shall continue to do that. In conclusion, distinguished guests, the launch of the Uganda Malaria Indicator Survey Report represents important milestones in strengthening Uganda's evidence base for decision making and reinforces our national commitment to using reliable statistics to guide the health interventions and development policy. I thank you very much and wish you nice deliberations.
Thank you, Dr. Albert Biamugisha, the Chairperson, Board of Directors, Uganda Bureau of Statistics. As he takes his seat, can we give him a very big hand clap? Our dear chief guest, before we continue, allow me to recognize the World Health Organization country representative and also head of mission, Dr. Kasonde Mwinga. She's right there. Again, permit me to recognize Dr. Akunda Karisa, Public Health Advisor, Office of Global Fund, Health Diplomacy, United States Embassy. She will be speaking shortly. Before you speak, they have a slot on the program, and we shall be listening from them. So, ladies and gentlemen, once again, thank you so much for being present. All those recognized and not recognized, your presence here is a demonstration of the importance that you attach to statistical information, and also not just information, but also the use of data in the entire planning processes, for which we highly appreciate you for making time to be with us here at the Uganda Bureau of Statistics. We are to have remarks from Minister of Health. I don't know if there is a representative present to give us remarks from the Minister of Health. We shall also be having remarks from Global Fund representative, then of course World Health Organization and the US Embassy. So can we have someone from the Minister of Health to give us remarks? If not present, I will proceed from Global Fund. Global Fund representative? Not yet around with us. I think they'll be joining us later. Let us have Dr. Cassandre to give us her remarks. A big hand clap for World Health Organization.
Thank you very much for giving me this opportunity. The chief guest, the Honorable Minister of State for Finance, Planning and Economic Development, Honorable Amos Lukolobi, the Uganda Bureau of Statistics leadership, the board chair, the board members and the executive director and the team, colleagues who may already be here or be on the way from the Global Fund and representatives of development partners, distinguished officials from the government of Uganda, ladies and gentlemen. Good morning. It is my honor and pleasure to join you to disseminate the 2024-2025 Uganda Malaria Indicator Survey. This is a significant milestone in our collective efforts to eliminate malaria and safeguard the health and well-being of all Ugandans. Uganda's progress is a testament to strong national leadership and effective partnerships. As we launch the 2024-2025 Malaria Indicator Survey report, I encourage all stakeholders to maintain high data quality standards, to promote timely data sharing, and champion the use of routine data in decision making. Honorable Minister, malaria remains one of Uganda's most persistent public health challenges. According to the World Malaria Report of 2025, an estimated 282 million malaria cases and 610,000 malaria-related deaths occurred globally in 2024. Unfortunately, this represents an increase of 9 million cases from the previous year. The World Health Organization African region continues to bear a really large proportion of the global malaria cases and deaths, up to 94-95%. And 10 countries in the African region, including Uganda, account for 66% of the global caseload. Ladies and gentlemen, these statistics represent lives lost, families affected, and communities constrained by a largely preventable disease. The World Health Organization continues to provide critical technical support to Uganda's malaria response. And in the past years, we have contributed to various national milestones, including the development of malaria elimination roadmap, the malaria elimination strategy, and the malaria mortality reduction strategy. WHO also supported the launch of the malaria vaccine, which is a tool in helping reduce the number of cases and deaths. And we will continue to stand with Uganda in its malaria elimination approach to accelerate progress towards achieving zero malaria deaths and advancing the national vision of a malaria-free Uganda. Going forward, WHO will continue to strengthen surveillance systems, enhance monitoring and evaluation capacity, and support operational research. We will also support quality assurance and robust data analysis to help the country prepare for emerging threats. WHO will continue to advocate for equitable access to new malaria tools and innovations. Honorable Minister, ladies and gentlemen, Uganda's malaria transmission patterns mirrors those of many countries in sub-Saharan Africa, and efforts to eliminate malaria are increasingly complicated by climate change, emerging biological threats, and also insufficient global financing. Protecting past gains and accelerating progress towards a malaria-free Uganda requires strategic planning and optimal use of available tools and resources. High quality, timely, and accessible data will remain fundamental to this effort. This survey is therefore an essential national exercise that demonstrates malaria's strong commitment to an evidence-based response, as had been also emphasized by the UBOS board chair during his remarks. The survey findings will support the implementation of Uganda Malaria Elimination Strategy for 2026 to 2030. It will also guide sub-national tailoring of interventions, efficient resource allocation, and program performance evaluation, again, as already indicated by the board chair. Previous survey results have highlighted that interventions do not yield a uniform impact across regions. Data-driven stratification is therefore crucial for targeted, cost-effective programming. This survey provides high-resolution information that enables government and government's partners to refine strategies, focus on efforts where needs are greatest, and ensure value for money. The World Health Organization encourages countries to conduct malaria indicator surveys approximately every 3 years to track progress and adjust strategies. This survey is thus a strategic investment in the health and future of every Ugandan. Remember that accurate data saves lives. I congratulate the government of Uganda and the Uganda Bureau of Statistics and all partners who have contributed to this important survey. I hereby reaffirm the World Health Organization's commitment to stand with Uganda, 1, as a strategic and technical partner, 2, as a source of global expertise, and 3, as an advocate for sustained investment and innovation on the journey towards a malaria-free future. Thank you very much.
Thank you so much, Doctor. Another big round of applause to Doctor, the country rep, World Health Organization, and also head of mission. Doctor, thank you for those very wonderful remarks. Critical to note is that you said the data is important in saving life. In instance, without data, we could be making mistakes in our strategies, in our planning, and even in our entire resource allocation. And Doctor, I want to thank you so much for emphasizing the role of data in the entire value chain and also in saving the life of every African, Ugandan, but also Africa. Thank you so much. We are going to have a remark then. Our dear chief guest, from the representative of the Ambassador, United States of America Embassy, Dr. Akunda. You're welcome.
Thank you so much. Good morning, everyone. Good morning, Honorable Amos Lugolobi, Minister of State for Planning, the Executive Director of the Uganda Bureau of Statistics, senior government officials, representatives of development partners, and all guests present. It's a privilege to join you for the launch of the Uganda Malaria Indicator Survey 2024-2025 report, an important milestone in our collective pursuit of strengthened public health and improved well-being for all. Malaria control is one of the 4 global goals that the U.S. Health Foreign Assistance will contribute towards, alongside reductions in HIV, TB, and polio eradication under the America First Global Health Strategy. This is critical to safeguarding the U.S. and other countries around the world. Mosquitoes do not respect borders, and controlling malaria, particularly as mosquitoes develop resistance to traditional prevention techniques, is vital to ensuring that malaria doesn't reach or reappear in countries where it has been eliminated, including the United States. For example, we have seen increases in the number of malaria cases in the US recently. Additionally, supporting malaria programs creates opportunities for American companies to deploy innovative tools and techniques in emerging markets, which strengthen U.S. global health leadership. Specifically, the United States is committed to supporting Uganda's vision of a malaria-free future and to contributing to 90% reduction in malaria incidence and mortality by 2030. The findings of the 2024-2025 Malaria Indicator Survey remind us that our work is far from over. While the report shows progress in some of the interventions like malaria preventative treatment during pregnancy and bednet use, it also shows that Uganda has stagnated or not taken to scale many of the interventions that the survey assessed. For instance, malaria prevalence increased from 10% in 2018-2019 to 13% in the 2024 to 2025 survey, and bednet ownership and access stagnated. Last week, the Honorable Minister of Health, Achang, and Ambassador Pop participated in the Community Health Extension Worker, or CHOOS, graduation event in Mbarara District. CHOOS provide the first line of care for children that develop early signs of malaria in many communities. However, only 35% of the households surveyed indicate that a CHOO or village health team or VHT member was conducting malaria testing, and only 53% of households report that a CHOO or VHT was distributing malaria medicines in their village. This is a clear example of where we need to use our valuable human resources more effectively for impact. The United States government is proud to continue its long-standing partnership with the government of Uganda in the fight against malaria. Between October 2024 and February 2026, we provided essential malaria commodities, including 2.6 million insecticide-treated mosquito nets, 4.5 million rapid detection tests, 2.2 million doses of treatment for uncomplicated malaria, and 200,000 treatment doses for severe malaria. We are funding an indoor residual spray campaign that commenced last month in 7 districts in eastern Uganda, targeting nearly 822,000 households and providing protection from malaria for about 2.9 million people. As I conclude, this report comes at a historic moment, following the signing of a 5-year, nearly $2.3 billion or 8 trillion Uganda shillings Memorandum of Understanding MOU on health cooperation between the United States and Uganda. This MOU reflects a shared commitment to life-saving services, resilient health systems, and the responsible use of American taxpayer dollars. It is an important part of the America First Global Health Strategy, which prioritizes self-reliance, national leadership, and durable systems that protect both Americans and Ugandans. The MIS report provides timely information to help us prioritize the most effective interventions for malaria prevention and control as we implement the MOU over the next 5 years. This MOU sets a new direction for our work together to contain the spread of infectious diseases, save lives, and enable economic growth. The United States will continue to work alongside the government of Uganda and all stakeholders so that every child, every family, and every community is protected from malaria. Each of us has a role to play. Together, we can reverse current trends, accelerate progress, and realize the vision of a malaria-free future. Thank you.
Ladies and gentlemen, I hope you have listened to American English. Dr. Kunda, thank you so much for that very wonderful remarks. Can we give her another big round of applause? Thank you. Thank you. Our dear chief guest, now we are going to the main gist of today. We are going to be demystifying and breaking down the findings from the survey. And I would like to call upon all our guests today to listen attentively so that we can pick issues here and there. So that when we get to the panel discussion, we get to the plenary, we have a full appreciation of today's dissemination. So I will request the ED with his delegation to take up this front pew so that we can be able to wholesomely follow the release. And you know, like ED said earlier, that it is equal access to information. Everyone receives data or official release at the same time. And that's what's going to be happening right now. So I request the technical team from the Uganda Bureau of Statistics to get set so that we are able to share these findings. Are we okay? Doctor, there, sit there. So, ladies and gentlemen, our dear chief guest, again, I take the opportunity to welcome our DED, Deputy Executive Director of UBOS, who will introduce the team to all of us. These are experts in statistics, and we expect to get actually the best. Dear Doctor, you are most welcome.
Thank you, Master of Ceremonies. As already mentioned, I'm Vincent Fred Senono. I'm the Deputy Executive Director. As by the Statistical Act, the ED, the Chief Statistician, has the obligation to officially announce the statistics by ensuring that the quality of statistics meet both national and international standard. So by the power entrusted to me by the ED, I call upon the presenters for today's Malaria Indicator Survey to present to the audience official statistics from Malaria Indicator Survey. This is Stephen Barahira. Stand up. Lilian Yakin. Overall, we have the director who was in charge of coordinating this survey, and that is Madame Helene Namilembenville. On this note, please, Stephen, come and officially present the findings to the audience.
Thank you. I've already been introduced, so I'll go straight to the point. That is the presentation outline. That is the presentation outline. We have an introduction. We shall talk about the objectives of the survey. We explain the methodology, and after that, we shall share key findings. I'm presenting with my colleague Lillian, so I will get somewhere and I invite her to continue. But mainly, I'm presenting the methodology and some of the key findings at the household level and the women respondents. This survey is the fourth in a series of standalone malaria indicator surveys that the Bureau has undertaken. It was implemented by Uganda Bureau of Statistics, and we worked with the Ministry of Health. Laboratory testing of the malaria was conducted by the National Health Laboratory Services, which is the Central Public Health Laboratory in Butabika. And we got technical support from ICF under the DHS program and the World Health Organization. The ED had already informed you about people who supported in this activity, so that is the acknowledgement. Now I go to the survey objectives. The general objective was to generate updated estimates of key malaria indicators, both demographic and health, in Uganda to inform malaria prevention, diagnosis, and treatment. And the specific ones were to measure the coverage of malaria prevention interventions, such as insecticide-treated nets, whom we normally refer to as ITNs, indoor residual spraying, and intermittent preventative treatment of pregnant women, IPT, to assess the treatment practices for malaria among children under age 5. The second specific objective was to obtain population-based estimates of malaria indicators, including prevalence of malaria among children aged 6 to 59 months. The other one was to measure knowledge, attitudes, and practices related to malaria prevention and treatment. Survey design. This survey was designed using the sampling frame from the 2024 population and housing census for non-refugee areas. We all may recall, those of us who live in Uganda, that in May of 2024, we undertook a census of all the inhabitants who had stayed here on the census night 9th to 10th. And this census gave us a frame, which frame was used to start doing surveys after that census. Now, this malaria indicator survey was among the very first ones. So we took this survey and selected clusters from both rural and urban. And after selecting the clusters, we would also select households, both in the rural and urban areas. We selected more in the urban areas because we know the population in urban areas is more fragile, and we didn't want to do a listing since we had just done a census. Every time we do a survey, we normally do a listing to make sure we have an updated list of all households in those enumeration areas. But this time, because we had just done the census, we didn't do a listing. We just selected clusters, and we selected households, and we went looking for those specific households. So it was 2-stage because the selection was done at 2 stages. If we were selecting women not doing all of them, that would make it a 3-stage. That's how we call it a 2-stage. Now, within the selected households, we interviewed all women aged 15 to 49, and the reasons, I don't want men to ask me, why did you pick women and you didn't pick men? The reason is because women is a high-risk group and biological susceptible, and on top of that, they're the ones who make most of the decisions related to household health, and they are the chief caregivers of the children in the households that we have. And you know, we were also targeting children in the next of 6 to 59 months who were testing for malaria, so their mothers needed to be the ones to hand them over to us or the other caregivers for us to be able to cover them. This survey gives estimates at the national level. So we shall be getting results for Uganda. We shall also get results for rural urban. We had enough clusters or enumeration areas to talk about rural urban. And of course, we had enough sample to talk about the 15 statistical regions we have where we normally disaggregate up to. That is the map of Uganda showing the different sub-regions and the clusters that we covered. The yellow dots are for rural clusters, whereas for the red dots are for the urban enumeration areas. You'll excuse me, I use clusters and enumeration areas, but they mean the same thing. Now, the whole process is shared here. We had stakeholder consultations. After stakeholder consultations on agreeing what to include in the malaria survey, we had the questionnaire development. We had the training of trainers. After training trainers, we recruited and then trained those staff. Then we carried out data collection. After data collection, we had to do data processing and management of the data. We did data analysis and report writing, and here we are now today disseminating the report from this survey. The survey training, we had the training of trainers, which was undertaken here in Kampala for 16 UBOS staff. This was undertaken with the help of ICF and the Ministry of Health were also part of it. Then we also did the biomarker training of trainers. This one was undertaken between 30th and 4th November. All these were provided from Ministry of Health, the ones who were going to be regional coordinators assisting in the collection of samples. And then the main training, I remember, was undertaken at Silver Springs Hotel for 21 days for all the field workers that were to deploy in the survey. We had a total of 23 teams, and each team comprised of a team leader, whom we call a supervisor. We had 2 interviewers, and we had an additional interviewer who would also work as a nurse. And the purpose of this one was to treat any children that we found with malaria having been tested using RDT, and they give them treatment using ACTs. We had this medication also organized for us by Ministry of Health. So the purpose of that nurse was to do interviews and at the same time to treat the children who were diagnosed with malaria. But those who had severe malaria, would be referred to health facilities for further treatment. Then, as I informed you earlier, we were taking blood from children aged 6 months to 59 months. So every team had 2 health technicians who were trained on how to draw that blood, either from the finger or from the heel. And the blood would be managed, would be tested. After testing, the other blood would be managed to be sent to the central lab in Tabika, here in Kampala. So field work was conducted from the end of November up to 3rd February 2025. And we collected this data using computer-assisted personal interviews, the copies, and we would be sending data real time to UBOS. Data processing, conducted processing personnel conducting data editing using CS Pro. Now, as regards malaria testing, we did this in 659 months in selected households with the consent of the parent or the guardian. We had consent statements that are all included in the report that we would have to give these people and they consent such that we take their children's blood or not where they are not comfortable, but we do not force anybody. But most of them responded in the affirmative, as you will see from the results. Blood samples were collected through the finger or the heel by trained the health technicians, and we used the rapid diagnostic test to test the parasites that are within that blood. RDT results were available in 15 minutes and were immediately shared with the caregivers of those children. Children who tested positive were given ACTs, and all those who were serious were referred to health facilities. In the laboratory were mainly testing for microscopy and PCR, where dry blood spots were analyzing using real-time PCR to detect DNA and identify species. So these were more sensitive tests than the field RDT test that we had used. We used 3 questionnaires. The household questionnaire. The household questionnaire was the main entry to the household because it would give us a list of all household members and visitors, and this one would guide us to identify the eligible members. You have seen we're not interviewing anybody, but we're interviewing women 15 to 49. So we would get all of this information from the household. In addition to that, we would get information about their age, their sex, their education, and a few other demographic characteristics. Then we would look at the household and look at the housing characteristics, the type of house they live in, the type of fuel, cooking fuel they use, the toilets they use. All of that information is included in the report. Then we would also look at ownership of durable goods, if they have a television or a radio or a car, whatever they have to use for anything that can help them in the day-to-day activities. Then we had the woman questionnaire, where the woman questionnaire would get those background characteristics. Then we get the reproductive history of the most recent children. Then we ask them about the pregnancy and intermittent preventive treatment. Then we would ask them about malaria in children, whether any children were sick 2 weeks preceding the survey, and what they did when the children fell sick. Then we would also ask them the knowledge they have on malaria and what they believe and the practices. Then the biomarkers is what I explained earlier. All of this information will also be recorded in the biomarker questionnaire. In addition to what was done, the results would be recorded there and they would be entered also. They would be captured. So the response rate, this one tells us about the response rate. We can see we selected 10,011 households, and of those households selected, we found that we selected 9,584. And of those households we selected, we found 9,458 were interviewed, the ones we interviewed. So the response rate for households was 99%. Now for the eligible women, we had 9,530 eligible women, and we were able to interview 9,238, giving a response rate of 97%. Those other numbers were mainly due to the fact you would get maybe a lady of 15 or 16 years, you say they're eligible, you record it on the questionnaire, they slept in the household, but at the time of the interview, they are not there, and you are there for a day or two, and they, you know, when they had slept there, but then at the time of interview, they are not there. Or some of them refuse. You get them, and then they refuse, but you can see the numbers are very small. Now, this is to do with the testing, the response rate on the testing. We were able to test 96% of the children aged 6 to 59 months. We were able to test 96% in the field. And of those who were able to test, all of their samples were tested even in the laboratory here. The same thing happens to your children. You would identify children between 0 to 59 months, almost coming to 5 years. But by the time you come to breed in the house, you find maybe some have gone away, or indeed, as we said, some of them, their caregivers refuse that I don't want my child to be pricked. So that is the 4% that we have there, which is not adding up to 100. Now next, we look at the survey results. We looked at the household population, and we found out from the information that we collected that 48% of the Ugandan population was aged under 15%, and 30% of the households, or 3 in every 10 households, were headed by women. We also covered literacy, and literacy is normally defined as the ability to read and write meaningfully. Here, what we did was to determine that any woman 15 to 49 years who had completed the secondary and above would automatically make them literate, that these are literate. But all the others who are below that, we had written statements that we would give to them in their respective languages for them to read, and then the interviewers will confirm that this one is reading properly, or this one has problems in reading this text. So the results show that nationally, women of that age, of reproductive age, 77% were literate, and this literacy was highest in urban areas, 85%, compared to rural areas, 71%. We also asked about household possession of communication, information, and technology, ICT. And we asked this by rural-urban. So the findings show that at household level, 54% reported that they had a radio, and this was more in urban, 59 versus 51. 29% reported they had a TV, and this was also the same, 45% in urban and 29 in rural, and rather 18 in rural. And then mobile phone, this is at household level. If any person at the household had a phone, then we would say that this household has a phone. So 85% of households had a person who had a phone. a mobile phone, and still this one 91% in urban and 81% in rural. We also asked about a computer, if a household owned the computer, and only 4% of the household had a computer, with 70% in urban and 2% in rural. We asked about women aged 15 to 49, if they had been exposed to certain media on a weekly basis. We would ask them whether they read a newspaper or a magazine in the past 7 days, or whether they listened to the radio in the past 7 days, where they watched television at least once in the week that preceded the survey. And these are the results. 70% had read a newspaper or a magazine, 31% had watched TV, 47% had listened to a radio in the past week, and only 3% had read a newspaper, listened to television, and rather watched television and listened to a radio. Now, the ones who reported that they had not used these media is 40%. But we know we have other media, maybe the phone, where people may have access to other information using the phone, but we didn't ask that. We asked these three: newspaper, television, and radio. So it may not necessarily imply that the other people, those 40%, didn't get any message related to any of the, related to malaria or any other health issues. I had shown a slide earlier which was showing mobile phone ownership at household level. This one looks at individual level. Of those women we covered, 15 to 49, we found out 16%, rather 62% owned any mobile phone, and 22% owned a smartphone, which means the difference, the 40%, 62 minus 22, are the ones who have the katochi or the button, the one they used to call the button phone. Now we also asked that same group of women whether they had ever used the internet. 27% reported they had used the internet ever in life. And when we zeroed it down to the past 12 months, the number slightly reduced from 27 to 25. 25% are the ones who had used the internet in the last 12 months. So I have ended at that one. I will call my colleague, our doctor, epidemiologist, statistician, to come and pick up from the malaria onwards.
I would like to stand on the protocol already established. Good afternoon, ladies and gentlemen. I'm going to be presenting results, findings on malaria prevention. From the results from the survey, we realized that that Ministry of Health recommends malaria prevention at household level, And this is from the Uganda Malaria Reduction and Elimination Strategic Plan 2021 to 2025, where they are looking at malaria reduction and interventions, whereby we look at the use of insecticide-treated mosquito nets, indoor residual spraying, and intermittent preventive treatment for pregnant women. In the UMIS, the Malaria Indicator Survey 2024-2025, we collected data on mosquito net ownership. We also looked at indoor spraying coverage and also uptake of the preventive treatment during pregnancy. So when we look at ownership of mosquito nets in Uganda, this is a question that we asked for all households, if at all they have any type of mosquito net. So we are looking at specifically all nets within the household, whether treated or not. So from our survey, we realized that there's no difference with the percentage of the household that owned any type of mosquito net, and also those with the ones that had any insecticide-treated net. So what would happen in the field? We go to the field, we ask for the nets within the household. So they give you the nets. Then the interviewer would have to identify whether it's a treated mosquito net or not. So that's when we come. Any mosquito net that was not treated was under any other net. So we can see that the national percentage is at 87% for ownership for any type of mosquito net, whether treated or not treated. Then for those ones that are treated, it's 84%. And we can see that there's no difference when you look at the urban and rural. As we have said before, like when you check also the percentage of household with at least one ITN in every household, we can see the national value is at 84%, and then we see the highest in Teso and the lowest in Kampala at 69. Looking at the trends, during the survey, we could ask also ITNs and then also account for each ITN within the household. So it's required that at least we have one ITN for every 2 people in the household, because this is a recommendation from WHO for control of of the design, which is designed to ensure that at least every 2 people in the household have one net as a standard. So when we look there, the percentage of households with at least one net which is treated, and also household with at least one for every 2, we see that the percentage for those ones that have at least one net for every 2 people has actually remained the same if you look at the UMIS of 2018 and the UMIS of 2024-2025. When you look at the coverage of ITNs, we can see that we have at 56% of the whole household population with at least one net for every 2 people in the household. What does that imply? That at least, if it's recommended that at least we have one net for every 2 people in the household. If I've come to your household and you are 4 people and you tell me that you have 2 nets, we attach every net to at least one person. I mean to two people. So it means that we have full coverage for that household, because there are 4 people and we have 2 nets. But if we come to the household and we have 2 nets and you're 5 people, that means that one person is not meeting the criteria that is used. So those ones are under 28%, whereby at least one ITN, but not enough for all the household members. Then also we have a percentage of 16%. Remember earlier we said the national coverage of ITN for at least one ITN in every household was 84. So the 16% actually do not have ITNs in their households. So now we come to access and use of those nets. So here when we talk about access, access means that the percentage of the household population that could sleep up to 2 people in every net, the 1-to-2 ratio that we have been talking about. So if you're 3 people and you have 1 net, that means 1 person cannot access a net. So we can see that at the national level, we have 71% of the households that can have access to an ITN. Then we have, when you look at the urban-rural, the difference is also not really, there's no difference, there's not much difference. Now, after accessing the net, did you really sleep in that net the night before the survey, the last night? So the question would be asked, did anyone sleep under this mosquito net the last night for the treated nets? So we can say that the people who have slept under the ITNs the previous night, we had it at 65% at the national level. So when we look at the trends in the ITN access and use, we can see that access also has not really, has also more or less stagnated. And then those ones who are actually sleeping under ITNs has increased from 59 of UMIS of 2019 to 65 for UMIS of 2024-2025. So now we want to assess at household level. For example, when you come to the household, we can see the percentage. Earlier we talked about those ones who had slept under an ITN the night before the survey. That is among all households. So we can see 65% of all members in the household slept under an ITN the night before the survey. Then now we look at these vulnerable groups where we have children under 5 and then the pregnant women. As it's recommended, any child below the age of 5 should be at least sleeping in an ITN, and also all pregnant women should be sleeping under an ITN. So we can see that at household level, we see that all households, we see 69% of the children in those households were able to sleep under the treated mosquito nets. Then pregnant women, we had it at 72%. Looking at the other side, we look at now those ones who slept under an ITN for the households that actually do have an ITN. The other one was for all households. Now we are looking at only households. You have an ITN in the household, but do people really actually sleep under it? So we are looking at the percentage of those who slept under an ITN a night before the survey. All household members, we can sit at 76% for the households that have an ITN. Then the children was 78%, and for pregnant women was 84%. So this is the sub-regional variations. So we can see that for percentage of children who slept under an ITN the night before the survey, we have it highest in Lango, and then the lowest was in Kampala still. Looking at the trends in use of ITN among children under 5 and also pregnant women, we also see some improvement from 2018 at 60 for children and 65 for pregnant women, all increasing to 69 and 72 respectively for UMIS 2024-2025. Now, remember we first accounted for all nets in the households. We come to your house, the interviewer marks all the nets. Actually, you will bring either the respondent will bring all the nets, we check them, and then put a code on them. Then we ask for every net that was used in the household. So you had to account for each net within the household. So we would ask, did anyone sleep under this mosquito net? That particular net, if someone slept under it, you say the yes or no. So if it was a yes, they would ask who slept under that mosquito net. remember we already had a list of the household members. So you attach every household member to a net, which they actually used last night. So if it was no, for any net that they say, okay, this one here, no one slept under it, we had to ask for the reason why that particular net was not used. So we can see from there, we can see that 65% mentioned that actually that particular net was an extra net, or rather they were saving it for later use. And also some households reported that they did not sleep under that mosquito net because probably the person, the respondent or someone did not sleep in that household last night, which is at 9%, with other reasons as outlined. So when we come to other prevention, another prevention measure, so as we have IRS, which is the indoor residual spraying against mosquitoes in the last 12 months. So IRS is one of the vector control methods which was recommended by WHO for malaria prevention. This one was introduced in 2007, but by the time of the survey, we had about 20 districts that we relied on. But around 2007, it was actually introduced in northern Uganda and eastern Uganda. So we can see that because it's for specific highly endemic districts, you see the national figure is actually at 10%. Doesn't mean that it's not happening in the whole country, but it's for specific areas. That's why we have it at 10%. And we are going to be looking at these particular districts so that we can see what's actually happening there. So when you look at the indoor residual spraying districts, that's the red bar, you see it's at 81%. So that's, I think now you can see why the national value is low, because it's for specific districts. And then for the seasonal malaria chemo prevention districts, so seasonal malaria chemo prevention districts, those ones are districts whereby, the 9 districts whereby usually whenever there is a high peak of malaria in that particular area, the children who are under 5 are given some medication to control to prevent them from getting malaria or to do the control. Then the high altitude districts, as we can see. So the percentage of IRS in those districts, we can now see it's at 81%. So now we are here to the pregnant woman. This pregnant woman is required to attend antenatal care. And whenever you go for antenatal, I think ladies in the house can believe that whenever you go there, at least sometimes within the trimester, they are supposed to give you an SP Fansida. We call it Fansida because that's what the Ministry of Health recommended to be given to every woman for each antenatal visit. And within we have about three. Now for each of those trimesters, at least they should administer a dose of what? Of Fansida. Meaning that we expect that at least every pregnant woman gets at least 3 doses of SP Fansida during pregnancy. So let us see what is happening. So now we can see that the number of those ones who actually got only 1 dose, it's 95%. Why is it happening like that? They only got 1 plus 1 or more. They got 95% got 1 or more doses of SP Fansida. Then 87 had 2 or more SP Fansida doses. Then we have, when you look at the recommendation of 3 or more, we see it at 73%. So what is happening in your sub-region for the women who have received more than 3 doses of what? Of SP Fansida. We see it highest in Toro sub-region and then lowest in Acholi sub-region. So now also when we look at the trends over the past UMIS that we have conducted, we can see that there has been some improvement in those ones who have taken 3 doses or more. So we can see it, we have 41% during 2018, and then now we are standing at 73%, which is not really bad, I think. So now for those ones who did not take the recommended dose of at least 3, what were the reasons? So the women were asked why did they take less than the three doses which are recommended during their pregnancy. So some of them say they were not actually aware that they had to take more. What does that mean? They were not aware. They go to the hospital, whatever they give them is what they take, and then they go home, but they don't know whether they're actually supposed to take more medication or not. And also then we can see a 10% there where they're saying drugs are not available. The drugs are not available. And then we have 6.9, which is saying facilities are actually too far. So we are now looking at management of fever and malaria in children. As we can see that case management is very key in the prevention and control of malaria, because when you seek treatment, you seek advice early, it improves the diagnosis and also treatment outcomes of the situation at hand. So now we can see, when you look at fever in children, so this question was asked for all children, but we're basing on the fever that must have occurred within 2 weeks before the survey. So we asked for if at all the child had a fever in the 2 weeks before the survey or in the past 2 weeks, and then we had 31% of the children having had fever in the 2 weeks before the survey. Now, of those children, the 31% who had a fever, we would go ahead and ask, was advice or treatment sought for those particular children? So we can see that we are standing at 84% for those ones at least who sought advice or treatment when the child had a fever. Now, it's also very key, also the timing of you seeking the advice. You might have gone when the case is actually, the treatment needed, the person is really badly off. So we had to also establish, was actually this advice or treatment sought on the same day or at least the next day. It might have occurred maybe at night, where a kid had a fever in the night, and then you probably go to the hospital the next day. So we have 54% of those ones that sought advice or treatment on the same or the next day. So after seeking advice, what happened? Did they take blood from this child so that they can actually confirm whether it's a fever, or you went to a drug shop, sought advice, they gave you the medication, this one, she's just feeling hot, let me give you some Panadol, and then you went back home. They did not confirm probably whether you have the malaria. So for those ones who sought advice, we can see that 57% of the children under 5 that had a fever, we had their blood taken from their finger or heel for testing, just to confirm, so that they can be able to know which medication is to give. You might just be having a fever, maybe it's due to some infection, but not actually malaria. So when you look at the trends, the case management of fever in children, we can see that those ones who are seeking advice is a little bit going low. I don't know why. Then when you look at those ones actually who have sought advice, we are seeing that their blood is actually being taken for testing. This one helps. It helps for early diagnosis and also improves the treatment outcomes. So now for children under 5 with a fever, before the survey who took antimalarials, we had to, of course we would ask you, if you went to the hospital, did they give the child any antimalarials, any type of medication? So they would tell us whether they were given the medication, and then we can see that 87% had actually been given artemisinin-based combination therapy, the ACT, which is treatment for malaria. And we have it at 87%, and all other types of medication that were given to these children. So now, where is the prevalence? The prevalence of malaria among children, we are going to use the results of microscopy. It's a confirmatory test. Remember that at the field, we're doing RDT, and then this one is more sensitive, and then we also had a PCR. So we are going to take results of the microscopy for now, and also in the report has all the other tests and their prevalences. So we can see that that the prevalence of malaria is actually increasing with increase in age, meaning as the child is growing up, they are becoming more susceptible for malaria. And then what does that imply? What does that imply? It implies that, you see, the young children, the young children live in a more controlled environment. You are a mother, you have to ensure the child is sleeping under a mosquito net. When it's getting a fever, you're rushing to the hospital to check out. And also, they are also breastfeeding, especially those ones who are not even 2 years. They are breastfeeding, so they have the mother's immunity. They have that immunity. They have a stronger immunity. But now the older children, you see them, they are not living in more controlled environment. They move up and down. They go in different environments. So I think that's why we expect that as age increases, this person's immunity has lowered, and then they are more susceptible for malaria. Looking at sub-region, now children who had a positive microscopy, using the positive microscopy at sub-region levels, we can see that it is also high. It's around 32 in Lango sub-region, and lowest in Chigezi sub-region. And then also Kampala at 1%. So prevalence in malaria in children by worth quintile. So we can see that those ones living in very poor households, it's at 23. And those ones in the richer, the wealthier people, we're having it at 2. So everyone should struggle to make sure that they are in the wealthier side so that we do not have the prevalence. So looking at the trends of malaria among children, when we consider the past UMIS, we see it has increased slightly for various reasons, probably. So now we usually have communication messages. People are sending out message. We always hear those malaria adverts and all that. So here we assess the malaria knowledge, attitudes, and behavior, whereby we assess how malaria information and communication messages reach women 15 to 49. So also assess which channels actually they are also using. So for women aged 15 to 49 who still all had a malaria message in the past 6 months, we can see its national value is at 48% of the women aged 15 to 49 had seen or had a message on malaria in the last 6 months. And then when we look at the residents were urban and rural, we see those ones in urban it's higher, and then for rural it's a little bit low. So now that you had a message, where did you hear it from? So we are looking at the sources of the malaria message, the main source that they use. So we can see 56% actually had it from radio. So when you're designing any communication material for women, so you can see which channel actually you have to use when you're going to give out this information. And then we had 27% who are saying, 28%, about 28% which were saying television, and all others. So also women aged 15 to 49 were asked whether they know that there are ways to avoid getting malaria. So we can see that the more educated, the ones who had a higher education attainment actually, at national level, the women who knew ways of avoiding malaria was about 93%. Then when you come down to education level, the ones who had more than secondary had 99. But the difference is a little bit not so different with those ones who had primary education. So also women had to cite specific ways. Yes, you know about the ways to avoid malaria, but we had to ask for you to tell us which ways do you think are specific ways to avoid getting malaria. We see 97% of those women telling us that sleeping under a mosquito net was one of the ways to avoid getting malaria. But those ones also saying that keeping the surroundings clean at 40%. And then also ability to cover those water puddles in case you have the water puddles, and you have to cover them to avoid them from being the breeding areas for the vector. So also women also had to express specific perceptions. Here we are looking at susceptibility, severity, and self-efficacy. So for the women who are 87% feel that their families and communities are at a risk of getting malaria, that their communities that are highly susceptible to get malaria. Then after knowing that the family is probably susceptible, do you feel the impact of malaria, the severity of the dangers of malaria? So we see 71% feel that the consequences of malaria are very serious. And then also the 86% feel confident in their ability to perform specific malaria-related behaviors. So I'll dive into the summary of the findings at the household population level. So we saw 9% of the women had never attended school, 27% had never used internet, 84% of households at least owned an ITN, then 71% of households had access to an ITN, 65% of household members also slept under an ITN a night before the survey, then 69% of the children also slept under an ITN. Then we have 72 of pregnant women who also slept in the net a night before the survey. Also, we saw that 73% of the women also took 3 doses of SP Fancida. 57% of children with fever in the last 2 weeks also had their blood taken. Microscopy results showed prevalence of malaria at 13% among children 6 to 59, and also 93% of women knew that there are ways to avoid getting malaria. 48 of the women also had seen or had a message about malaria, and the radio being the main source at 56%. I would like to take you now to the refugee settlements. We are now out of the household population. We are now in the refugee area. So from the refugee side, as my colleague already explained, we used a separate frame where we selected with separate list of the frame of 935, and also the refugee village size also varied from 1 to 2,012 households per village. And these are the refugee areas, the settlements as shown. So when you look at the refugee settlement, ownership of mosquito nets, for any mosquito net was about 52%, and those ones that had an ITN, the treated insecticide mosquito net, was at 51. Then also when you look at those percentage of households with at least 1 net for every 2 people, meeting the other recommendation, we see it at who stayed in the house, the percentage of households with at least 1 net for every 2 persons who stayed in the household the night before the survey. For any net that was used, we see it at 21, and for a specific ITN, we see it at about 21%. So use of mosquito nets by children in refugee settlements. We see that children under 5 in all households who slept under any mosquito net a night before, whether it was treated or not, it was at 37%. And those ones who slept under an ITN, the treated mosquito net, it was 37%, which is more or less the same. Then children, the household with at least one ITN, who slept under an ITN in that the night before the survey. For those ones with households that have an ITN, we see it at 69.7%. Also use of mosquito nets by pregnant women. So women who slept under any type of mosquito net is not so different with those ones who slept under an ITN in all households. And for the households that have at least an ITN, we see it at about 78%. So also children with fever and care seeking, prompt treatment and diagnosis. We can see that in the refugee settlements, we had 25% of the children who had a fever in the last 2 weeks before the survey. And out of this, we see 79.5 who sought advice or treatment when they actually had the fever. Then we have 60% of the children whose blood was taken from their finger for testing. And those ones that were diagnosed with malaria by the healthcare provider when they went for testing was at about 51%. Prevalence of malaria in children at refugee settlement using different tests. I'm going to specifically look at the microscopy. It was at 9.8%. Ladies and gentlemen, I would like to thank you so much for giving us time to present to you the key findings from Malaria Indicator Survey 2024-2025. Thank you so much.
Thank you, Lillian. With permission of the Chief Statistician, you qualify to be called Malaria Statistical Technocrat. A big hand clap to Lillian for such a wonderful presentation. And you may realize that there have been a lot of technical jargons in Lillian's presentations, a lot of scientific findings, blood sample, plasma, net, PCR, case management, positive microscopy test, and so on and so forth. Now, to the members of the media, when you get to reporting this scientific information, you should be careful with using these words and use them only where they are appropriate. That's why I'm emphasizing. Can we clap for Lillian again for bringing out these technical jargons? Now, where I come from, they are white ants. I will tell you that story. But before I tell you that story, allow me to invite ED with the board chair and all the members who are up here to come back to the main table. Now, there are white ants in my area. The other side that I come from, again, they are not white ants, but they have karibu. They have, in Senen it's called what? Grasshoppers. Now, grasshoppers is trapped using electricity and very white iron sheets. That's how they trap grasshoppers, isn't it? Members who eat grasshoppers, are you here? That's what I've seen. Now the other side, the white ants, they have modified the way of trapping it. They now use mosquito nets. So one day I was passing and I made a stopover and I asked them, these mosquito nets that you're using to trap white ants, are they the ones you're using at home or Then they said that, we are using the old ones. So that means that actually the government has invested a lot in what? In mosquito nets, isn't it? So we must thank them. That enough people even have extra to use for trapping white ants. So let's clap for the government of Uganda. Thank you. After listening to this very wonderful presentation, we are supposed to receive a very important message from our chief guest, who's the minister. And in a very few minutes, he's going to be doing that. But we'll also launch this report for use going forward. But again, we want to thank all of you who have come and have spared all your time from 10 when we started. We have Honorable Nakato from Office of the President, Commissioner RDC Secretariat. She's here. Madam, you are most welcome. Thank you so much for coming. And all the other statistics users who are present here with us. Our dear chief guest, we want to say thank you so much again for sparing your very busy moment to be here for this beautiful dissemination. I will be taking this opportunity to invite our board chair, who will of course invite you. But before I do that, allow me to inform. I know some of the audience, the distinguished guests and ladies who are here, ladies and gentlemen who are here, they may be aware of this declaration. Exactly 2 years ago, there was what we call the Yaoundé Declaration. And I'm going to read it. It is a landmark commitment which was signed on March 6th, 2024 by health ministers from 11 African nations, collectively accounting for over 70% of the global malaria burden to accelerate reduction of malaria mortality and work towards the goal that no one shall die from malaria. Now, this declaration was signed during the high burden impact which had been observed in Africa. So this was in Cameroon. But now the most interesting part is, among the core commitment, what they say, the core commitment, of course, it was signed by 11 countries: Burkina Faso, Cameroon, Democratic Republic of Congo, Ghana, Mali, Mozambique, Niger, Nigeria, Sudan, Uganda, and Tanzania. But now here is where you both place a very important aspect, where they said core commitments. The ministers pledged stronger leadership, increased domestic funding, improved data technology usage. Can we clap for the ED? Can we add the ED another big hand clap? Members from the other side. We are talking about a commitment by ministers of health from 11 African countries, and they are emphasizing this aspect: improved data technology usage and the application of the latest technical guidance to eliminate malaria. So, the product that is being released today, it is actually a core function towards eliminating malaria prevalence in Uganda. Can we clap again? So, on that note, allow me in a very special way to invite our board chairman, who will then invite our chief guest to speak to us, and thereafter he will have the privilege to launch the report.
Thank you once again, our Director of Ceremonies morning. Once again, with great respect, allow me to invite our guest of honor, who is our minister in charge of planning and statistics, to come and address us, and then after that you launch the report, because we want the news now. This early afternoon news to have the information on malaria. So we are inviting you to come and address the participants. Thank you very much.
Thank you so much, Board Chair, Dr. Albert. The chairperson and members of the Board of Directors of the Uganda Bureau of Statistics, the Executive Director and Management of WIBOS, representatives of the Ministry of Health, if they are here at all, our development partners, WHO, representative, distinguished guests, ladies and gentlemen. Good afternoon to you all. Are we in the afternoon yet? Okay. So I'm so pleased to join you today for the launch of the Uganda Malaria Indicator Survey Report, an important statistical product that provides critical evidence to guide sector planning. Allow me to begin by commending the Uganda Bureau of Statistics in collaboration with the Ministry of Health and our development partners, particularly the WHO, for successfully conducting this survey and producing this valuable report. Reliable and timely statistics, you'll agree with me, are essential for effective national planning, budgeting, and monitoring of development outcomes. And that one is a heavily loaded statement in the sense that it is combining planning, budgeting, and ultimately monitoring, and then the outcomes. There is a direct link between those four. Statistics, to begin with, is used to guide planning. And we do evidence-based planning. Why evidence-based planning? Because we rely on statistics. We cannot do planning without data. There are people who do not care about this, and they take decisions, their gut feeling decisions. And you have often seen people who make normative statements which are not backed up by any data. Someone will come to a conclusion, he will come to an area, and they say there's a lot of poverty here. Just normative like that, you know, that so many people are dying here without you asking for evidence, and it is not there. And I've seen authors who do not use any statistics at all, but they are making very fundamental statements. We have also been victims in certain cases where we take policy positions that are not backed up by data. So I really want to appreciate WIBOS that over the past few years, they have come of age, ensuring that we have timely data. I've been around for some time, and I've been observing. There was a time at the National Planning Authority would look for data, and data was as old as 8 years. You would not access latest information. As it is now, we actually use the latest data. Just done the census. These guys who are in statistics will remember how we struggled to do the other census, was it of 2014? We had a lapse of 2 years behind the schedule, you know, before the census was done. This time the census was done on time, and we now have all the data that we need, you know, and that is progress. Before, people would not see the value of statistics. You know, they would not understand. They would ask you, why would you spend over 300 billion in doing a census? Just a census, for what? You know, would rather use that money to construct a school. But I'm glad that most of the policy makers are now aware of the importance of statistics. And this has been evidenced in the report we have just seen now, with the numbers taking a different direction. And that is an outcome. You have seen from the graph that below 5 years, the prevalence rate has worsened from the previous survey from 10 to 13. And that is not good news for the policy makers. You then begin to ask questions. Where is the problem? And we need, after this one, to go and interrogate where is the problem. If we have been investing money, is the money too little, or the money is sufficient, but implementation is a problem? So we need to interrogate these problems, and therefore I'm saying that this exercise is not an end in itself. It should inform policy action after doing adequate research to find out where the problem is. We should not shy away from the problem. We should always expect such outcomes to appear. But I want to appreciate the fact that the trend since 2009 has been very progressive. We have seen a lot of improvement from 45 prevalence rate in 2009 now to 13%. It's only in 2018 when we had 10, but now slightly going upwards again. We shall not allow that trend to continue going upwards. We must make sure that malaria prevalence is reduced even further and totally eradicate these mosquitoes that are causing this malaria. As the minister responsible for economic planning and resource allocation, we rely heavily on the data produced by WBOS to inform policy decisions and ensure that public investments deliver tangible benefits to our citizens. When we say public investments, we are talking about the money we spend to set up all these investments that we are talking about. The work undertaken by WBOS in producing credible national statistics and the leadership of the Ministry of Health in implementing health programs are critical enablers for the successful implementation of government's 4ATM strategy, that is commercial agriculture, industrialization, tourism development, and mineral development. These strategic priority areas depend on a healthy, productive, and resilient population. Investments in health, therefore, contribute directly to building the human capital required to drive productivity, economic transformation, and sustainable development. You cannot have a productive workforce when people are dying of malaria. You saw the global statistic presented by the WHO representative that about 282 million people getting malaria, and about 610,000 of those dying of malaria. I don't remember which year she mentioned. But imagine 610,000 people. You know, we had a war in Israel, Palestine, and were so concerned when about 68,000 people died. But imagine 610,000 people just dying because of malaria. And this is why we are attaching a lot of importance to the prevalence of malaria in our country. And therefore, malaria continues to impose a significant health and economic burden on Uganda. Beyond its direct impact on health, malaria affects labor productivity, school attendance, household incomes, and overall economic performance, particularly in rural communities. Addressing malaria, therefore, requires not only strong public health interventions, but also sustained investment and effective use of resources. The findings of the Uganda Malaria Indicator Survey provide valuable insights that will enable government and partners to better understand malaria trends, target interventions in high-burden areas, and strengthen malaria prevention and treatment programs. From planning and financing perspective, this evidence is extremely important. Data generated from national surveys, such as this one, enables the government to prioritize investments in areas with the greatest need, improve efficiency in the use of public resources, to strengthen monitoring and accountability in the health sector. What UBOS is doing is helping us now to account, because now they are measuring the outcomes. So we need to strengthen this monitoring to make sure that we don't get consumed by the burden before we realize it. We need to support evidence-based policy and planning. The Ministry of Finance, Planning and Economic Development remains committed to supporting the production and the use of high-quality statistics, recognizing that sound data is fundamental to good planning, effective budgeting, and better development outcomes. We will therefore always ensure UBOS works at its best, and as well as continuing to work with the stakeholders, such as the Ministry of Health, the WHO here, and so many other actors and development partners, to strengthen Uganda's national statistical system and ensure that our development policies are guided by credible and reliable evidence. I'd like to really once again appreciate the UBOS. They have come a long way. When I came in, I found that there were a lot of problems, you know, internally, quarrels here and there, and I want to appreciate the ED and the board that you have overcome those problems. And we are now getting the results as expected. So that is a tremendous achievement, and they deserve another round of applause. Because now, the challenge today is not the absence of data. The challenge we have today are the users of this data. I don't know what we are going to do to make sure that people actually use this data. Because we are now oversupplying them with data. We are launching reports after reports, you know, every other day. I'm sure you are going to be invited very soon to receive another report and another one before we wind down this Chisanja. You should be able to see more launches of these reports. And I'm sure these reports are not coming by accident, but because of the hard work of the team that is behind it here. Please give them another round of applause. So as we launch this report today, I encourage policymakers, the researchers, you now already have a task, local governments and development partners, to make full use of the findings in designing and implementing interventions that will accelerate malaria control in Uganda. Let me specifically also appreciate the presenters, and I think they have presented it very well. We need to applaud them for that. Yeah, they demonstrated a lot of competency in transmitting the information to us. So by translating evidence into action, we can significantly reduce the malaria burden from that 13% you saw to somewhere, I don't know what the next target is, total elimination. Total elimination. Let's work towards 0% of malaria. In Uganda, I think we can do so. Me as a layman, I'm wondering why even we spend so much time on mosquito nets and we don't, spray these mosquitoes. At my home here, I spray. I go to a certain shop called MTK. They sell me some chemical that works for 6 months without seeing a mosquito around me. Now, I went to the village recently for campaigns. Within 1 week, I was hit by malaria. And I had to stay in the hospital for about 3 days for treating malaria. So I think the mechanism is used to eradicate malaria. The researchers should help us to see what is the best way to deal with this burden. So by translating evidence into action, we can significantly reduce the malaria burden, improve the well-being of our citizens, and strengthen the human capital required to support Uganda's socio-economic transformation. I thank you so much for your attention, for God and my country.
Thank you, our dear chief guest. Please, can we give him another big round of applause? And of course, chief guest, we shall not allow you to take your seats, but would like to invite you humbly to launch the report so that the whole country can receive this message at the same time. So, team, please let's be there. Representative of World Health Organization, ED, board members, please accompany the Honorable Minister. DED, please. Director Helen, you are appreciated here. You had just stepped out a little. I hope your recognition, you got the message over the rooftops. So let's have it open, John. Let's have this open. Yeah, they're going to cut the tape, and then we shall remove the... So in one go, malaria, no one should die of what? Thank you. And like the minister said, that it is actually possible. It is actually possible to have a Uganda-free malaria. So this is going to become maybe the next point of action. I just realized that, okay, we have the book available, but also we have a dummy report that is going to show the launch. So, Honorable Minister and our chief guest, we request that you sign, and then so that is signing of the report, and that marks the official dissemination of Malaria Indicator Survey Report 2025. After that session, we are going to have a group photo, and then we shall have the plenary so that we can ask the technocrat on malaria indicators. Lillian is here. We have Director Helen oversaw the process. We have Mr. Stephen Barahirwa, who will be able to answer to all of us some of the few questions that we may be tagging to this dissemination. So that is our board chairman signing. We have the ED, we have the ED, we have our other board member, Dr. Allen Kabagenyi. We have representative of World Health Organization, Office of the President, RDC Secretariat. Thank you so much. So we are going to have a group photo, and we shall actually be displaying even hard copy of the report, which is already printed. And for us who may be lucky, we shall be able to walk away with the hard copies so that we can go and, yes, we can read them, internalize them, and appreciate some of these very important indicators on malaria. I saw a representative from UNFPA, Florence. Is she still around? Okay. Okay. So we can have copies of the report. So we can take this position for the group photo. Dihidi here. Chairman is there. Let's come this side. Dr. Allen Kabagenyi. We can balance the boat so that we are gender balanced. Okay. Director. So we can display our physical reports. We are trying to balance the boat, yes. Leave it there. John, leave it there. Leave it there. Just leave it here. Yeah, leave it there. Yeah, it's part of the photo. Yes. A book, John? Another report here? I hope the cameras can pick all the important details here. Okay. A report, please, John. 2 reports. 3 reports. Yes. Here. Then him. You know, this is evidence-based institution. That is one of the culture that we really appreciate here. And so we are evidence-based, and we are glad to display this material and show to the whole Uganda country that this has been delivered. So once again, we thank our chief guest, the Honorable Minister for Planning, for taking us through today's session. If time could allow, you would have lunch with us because the ED has prepared for us lunch. After the plenary, all of us will be going to have very sumptuous lunch in the boardroom and elsewhere. A colleague of mine said,
I want to propose that we say zero to malaria by raising the book at a go.
zero malaria. Zero. Zero. Asante. By the way, our chief guest, again, we would like to let you know that we have been online since the beginning of this dissemination. We have been on YouTube channel, we have been on Zoom, we have been followed by the whole world. They have been seeing each and every activity that has been taking place in the conference hall here. So, while we have physical participation, we have also had online participants who have been following this entire program. So we are going to have a plenary, and I'm going to ask Lillian, Director, Mr. Barahirwa, to sit in that VIP table so that members can share their insights and you give them detailed or deeper understanding of this session. Please don't go. We are still continuing the program. Don't leave. It would be nice that you wait a little. I know the media would like to interview the minister, which is good, but the rest of us can remain and listen to this last part of the program. I expect the presenters to sit like minister, where the minister has been sitting, so that we can have more deeper discussion. And I'm going to ask, prepare your questions. We are going to move the microphone. You just lift up your hand and this technical team will be able to respond to you. It would be nice that also Dr. Senono joins them. Okay. Is there anyone with a burning question? Someone is saying yes. I had a yes and a no. A question to the team on the survey? Any burning question? There is a question there. Let me ask Mr. Habimana. Could you please come and help me move this microphone? There is a question at the back there. Kindly lift up your hand again so that he can see you. Thank you.
Thank you very much. My name is Joan from UBC, the National Public Broadcaster. First, I would love to commend you, boss, for partnering with the Ministry of Health in providing these surveys as government institutions. I have about 3 to 4 questions, and one, from the results of the survey, you have indicated that over 56% of households consume radio messages. And the second one was television, indicating that traditional media is the most common form of media that households do feed on. But apparently, there is there are sentiments that social media is taking over the traditional media. So I would love to know from you both, do you end at giving the Ministry of Health just the surveys, or you do give specific recommendations, and in this case, about the relevant channels of communication that they can relay their messages? The fact that the prevalence rate has moved from 10% to 13% with the current 2024-2025 Malaria Indicators Survey. And that is basing on the demographic data that UBOS collected. And another question about that is that most of the time, I think this is supposed to be for the Ministry of Health, it's okay. So, and are there any new indicators that were included in the 2024-2025 survey away from the previous ones that were used? And when will the microdata and detailed report be publicly accessible, and where, if possible? Then previously, we've seen UBOS partnering with some other agencies, for example, the DHS program. Did you carry out the survey this time around alone, or you had some partners that helped you in maybe the technical bit of it or trainings? Thank you.
Thank you. UBC TV. As we wait for any other question, I will ask the team to respond to those.
Thank you, UBC, for very important questions. You have asked about communication, how we picked radio, television. Is it possible to add relevant channels, especially social media? Yes, I think that is a very big concern now, based on how Uganda and the other countries are progressing in terms of getting information to people. If you are attentive, when I said that we asked for those television, newspaper, and the radio, I said 40% said they were not accessing any of those. But we know there are some other channels, especially when people have, at this era of phones and what, people must be accessing information on those channels. So you are right. I think we are going to introduce that issue of social media, and we see how many people are accessing this information on social media. And I think it is a very good way of communicating to the people all types of information, be it health or otherwise, to make sure it covers a lot of our communities. This, my other colleagues will add on where they need to, but I think let me first handle that. Were there any new indicators that were included, and where will the data and the report be? I don't remember any new information that we added. The new information that may be there will be in the analysis, especially in regard to the SDGs, which we are trying to respond to. If you look at the report, you will find out that there is some information that we are going to classify based on how they want us to report issues to do with sanitation and water use, drinking water. But otherwise, in terms of questions, I don't remember anything that we added that was new. We all used the old questionnaires and tried to make updates in terms of the coverage. Now, as regards the data and the report, the data is available. The data is 100% available. I can't, for users, the way we ask other data, or for other data, and it is also going to be uploaded on some website. The report, if I'm not mistaken, we told the dissemination team to upload it on UBOS website. Yeah, so the report must have already been uploaded now. This report that we are sharing here, it must already be on our website right from now. So whoever doesn't get a book, you can go and get this report directly, immediately from now. This report is already uploaded. The other question is, did you carry out the survey alone or you had other partners? This survey was done with the other partners, the way we introduced it. Of course, the main implementing agency was Uganda Bureau of Statistics, but we worked very closely with the Ministry of Health on all aspects of the survey. We had the ICF, who provided technical assistance. We had WHO, who were the chair of the technical, alternate chair of the technical working committee meetings for technical issues, in addition to members from the Presidential Malaria Initiative. So it was done with assistance, rather with support from other stakeholders. I don't know if there is anything I have not handled, but my colleagues can add on if there is anything I have not touched on.
Thank you, HOD, Mr. Barahiro. Do we have any other question? Abimana, please, here, there's a hand. Your name and the institution, then you go ahead with your question.
Good afternoon, everyone. Nansuma Nadira is my name, and I work with Radio PAL FM and GTV. PAL and GTV. My question is, what are the mechanisms that will be put in place to ensure that the survey findings lead to tangible improvement at community level?
Thank you, Radio 1.
Director, can I answer what also?
Thank you very much, sir. There are two issues I want to put up. I am Henry Baguma, UBC Radio. Number one is what next after this, because such reports are always made annually, but they go to the boardroom and that's a closed chapter until next time around. So what next after this? Number two, I would like to members to look at the program, and also if they have a watch to look at it and see it is now close to 1 something, and according to the program, it is supposed to be 135 closer. And given that background, therefore, I want to thank very, very much, to give a recommendation the organizers and the program managers for maintaining time in this activity. It's very rare in Uganda today. So I thank you very much for that.
Thank you. The question, I think the two questions are related, other than the last comment and commending us for keeping time. Somebody has asked, what mechanism are we putting in place to make sure this information reaches communities? We normally have regional dissemination, where regional disseminations are normally done at the sub-regional level. You saw us pointing here, the West Nile, Rango, Acholi, Teso, and what have you. But currently, the budget was not allowing those disseminations to take place. But since we have a number of stakeholders, and we have the ministry, which is the key user of these statistics, I think we are going to engage and see how we can have this information sent down to these communities the way we normally do with the other health surveys and other surveys like DHS and the Rusty Malaria Indicator Survey. Now, this one answers the one of what next after this, but just as I have told you, even the data that we have produced is available for people to use. So there may be some results which need further explanation, and we have other variables in the data that can explain that. So deep analysis of the data that we have is also welcome to make sure people understand what is causing some of the results that we are getting. I think that explains what the two people had asked.
Thank you. If there is no any other question, I will request our director. Or there's a question from RDC Secretariat.
Yes, thank you. I have a problem with my voice, but I just wanted to congratulate you for having successfully launched this survey. And also, I would like again to congratulate you, boss, for your improved performance, because the minister mentioned that when you joined the ministry, your performance was down, but now it is going up every day and night. So thank you for that. I lastly want to inquire whether you will avail us with copies of the presentations, especially from the minister, from the ED, because the survey we've got copies, but because your comments were so important as far as the survey report is concerned. Thank you.
Thank you very much, Office of the President. The rest of the information from the minister, from the ED, from the board chairperson, we can avail it because we have them. If there is no other question, and also the presentation, we are going to avail it to you. Yes, and any other stakeholder who's interested, it's a public information. Again, UBC has a question.
I just want to clarify on the question that I asked about the recommendations from UBOS to the Ministry of Health. Do you give the specific recommendations concerning the survey, for example, about media consumption? Because from the report, few people accessed the internet in the previous 12 months. I think it was at 25%. And for the radio and television, it was at, if I have my statistics right, at 54 and 56. So do you only end at giving them the survey, or you recommend that since malaria products or content is mainly consumed through traditional media, do you give them highlights, like you should put more emphasis on radio and television compared to social media or any other form? Because for what we've seen with Ministry of Health, malaria information, it's normally for a few months, and we no longer see the promotions and awareness. Yes, with media, especially traditional media, consistency is key.
Yeah, I think the question is well understood. When we come up with a report with all of these findings, this report, for your information, was prepared together with the Ministry of Health. The report writing workshops and what, they were part of the report writing. But when it comes to recommendation, it is them who pick the important what? The important points. And say, wait a minute. Oh, messages are only got by this what about, but for us, we can only point out in our stakeholder meetings and say, you know, there was a report showing that radio and TV were this much. But we know there is another form of communication that is there, which is social media. Can we take this one up? Such that in the next survey, we shall be able to include a question which captures that social media part that enlarges on the communication channels. That is what we do with our surveys. Where possible, sometimes we write those recommendations with them, or otherwise, we just point out those issues, and then in our stakeholder meetings, we just discuss these areas of improvement and other additions in terms of codes of what we are covering.
Thank you very much, Mr. Barahira, for those responses. I believe the people who asked questions are contented. I would also like to thank Mr. Baguma from UBC. Mr. Baguma, are you hearing me? I'd like to thank you for commending us on keeping time. We appreciate. Yes, like I said earlier, time is important, and keeping time is part of discipline. So we respect that from here you're going to do other things. So at this juncture, allow me to invite our Director, Population and Social Statistics, Madam Helen Vere, to give her closing remarks and declare this workshop closed. Thank you.
Thank you very much, our Director for Ceremonies. Colleagues, can we clap for ourselves? I know it is already 1:30, and I don't want to stand between your lunch. And so we are coming to the end of this meeting, and basically would like to thank everyone who has attended, who has participated. Many of our colleagues have left. And I don't know whether there are others still online. They are listening in. This has been a very big achievement, but we want to encourage you to pass on the message to the other people and look out on our communication handles. And we'll be giving more details about this. Stephen, I believe there's going to be a lot when we work with the Ministry of Health. I think they are going to write more papers, but still that will be the role of the policymakers. And please try to look out for all this information, but you can still get back to us and the ED, and they will provide those details. We are also grateful. We understand that we need to disseminate these results further, but as we had indicated, the resources permitting, will take up this matter. I believe since this is a recommendation for this meeting, we are going to pass it on to the Executive Director and inform him that the colleagues in the workshop, our participants, do want us to take these results further. We are aware, but there were some hiccups as we were preparing for this. So members, thank you very much for coming, and thank you very much for participating in this. And I want to declare this meeting officially closed.
Thank you, Director. Ladies and gentlemen, our distinguished guests, please, you're all welcome for a lunch. Leave when you have eaten. Just in case you have not taken your fasting seriously, please enjoy the lunch.